Welcome back. We are now in the digestive system. Boy, are we winding down. We're now getting into the first discussion on the anatomy of the digestive system, which is part A of a series of three PowerPoint groups. And let's take a look at the function. First, it was being used by the body to take in food, to break it down into nutrient molecules, to absorb molecules into the bloodstream, to get rid of any undigestible remains. And the organs are actually divided into two categories, into two groups. This will be the alimentary canal. This will be what you call commonly called gastrointestinal or the GI tract or simply the gut. And this is made up of continuous muscular tube that runs from the mouth all the way down to your anus. They digest food, they break down, they're actually broken down into smaller fragments. They absorb the fragments through the lining and it gets picked up by the blood. And then the organs of the gut or the GI tract is starts from the mouth, the pharynx, the esophagus, the stomach, the small intestine, the large intestine, and the anus. And then you have also the digestive organs. The digestive organs will be your teeth, your tongue, gallbladder, your digestive glands. These are the ones that produce secretions that help break down foodstuff, your salivary glands, your liver, your pancreas, and pretty much the cells that are involved in each of the accessory organs. And here's a good picture of it. And you are, I think, involved in the lab in studying already the parts of the digestive organs. So let's take a look at the processes involved in digestion. And there are six essential activities in it. Ingestion, which means this is the time when you're eating it, taking in food into your mouth. Propulsion, this is when you move the food that you've eaten through the alimentary canal, which includes swallowing, and then the peristalsis, which is a major means of propulsion of food that involves the alternating waves of contraction and relaxation of the longitudinal muscles and the circular muscles of the tube. And here's actually how peristalsis is shown in this picture. Take note that in the left picture, the adjacent segments of the alimentary canal organ would alternately contract and relax, and food is moved distally through the tract. And pretty much the primary action here is propulsion. And there could be some mixing, but it's all moving down. Now, on the other hand, the second part here, which is on the right picture right here, which is labeled segmentation, this will be like, well, picture. This is a special type of movement that happens within segments of the GI tract. Now, this particular segment is pretty much like moving like put it this way, like let's say a dryer. Okay. Now, now in the dryer, well, your clothes are actually being mixed while the hot air, is actually blowing in it. Could you imagine if there's going to be no mixing or no turning around of the uh, wet clothes is actually happening inside your dryer? Then, if it's only air that's going to be blowing and there's no movement of what it calls a mixing of the clothes inside the dryer, then only the outer portion that's being blown by the wind is going to be dry, and the rest of the other clothes will not dry up. So they thought of rotating the uh, what do you call this? The uh, rotating not only, well, the air is actually the one managing to put in the hot air, but the clothes that you're drying needs to be rotated. And this is exactly what segmentation is all about. If the enzymes are actually being secreted by the walls of the GI tract, now there should be a movement within those tiny segments that would move around and turn around the food on each segment so that each particular food particle are able to pick up the enzyme that is locally being secreted by the walls only. If they're not going to be turned around, then only those food materials that are very close to the wall will pick up the enzymes, and those are the only ones that gets to be digested. But that's not the way it is. We have to digest as much as possible all of the food material, all of the food that is actually in the tube, including the ones that are inside and the deepest on the center of the tube. And the only way to do it will be to move them, turn them around. Like this is actually the movement. The turning around movement is what you call segmentation. So the digestive process is made up of mechanical breakdown. That means food is being chewed. There's actually mixing with the saliva, churning of food in the stomach, and also the segmentation process, which is just like what I told you, is a local turning around of the food by constriction of the intestine, so that food can be mixed with the digestive juices. And digestion is a series of catabolic steps that include enzymes that break down complex food molecules into chemical building blocks. And then you have absorption, which is the passage of the digestive fragments from the lumen of the GI tract into the blood or lymph itself. And then finally, the last action or the last process will be defecation. It's the elimination of indigestible substances right through the anus in the form of your fecal matter. And there are many activities that are involved, and this is a good picture just to show you visually what they are. You got your ingestion, mechanical breakdown, your digestion, well, before digestion, you got the propulsion, then digestion, then absorption, and finally defecation. So let's take a look at the organization of the digestive system. The digestive system is inside your body. And being that it is inside the body cavity, it cannot just be dumped there. It has to be organized in such a way that even if you are moving, they're not going to be, because they're it's actually long, like they're not only made up of short tube that extends from your mouth to your anus. They are actually highly coiled tubes. In order to avoid them tubes interlocking with one another and pretty much like doing a lot of congestion inside your inside your abdominal cavity, then there are specialized uh, connective tissues that hold them together. And these connective tissues happen to be the extensions of the peritoneum. Okay? So the peritoneum, first of all, is the membrane that covers the abdominal cavity. You call it the parietal peritoneum. And as the peritoneum is actually a point of anchorage also for the internal organs, the gut itself, in order that the gut is not going to be all over the place, uh, they extend, the visceral peritoneum extends membranes that would be connecting into the digestive organs, and you call them uh, the mesenteries, okay, and the omentum that holds these organs together. And then finally they go around and cover. The peritoneum itself would, in the end, will be wrapping themselves around each of the organ, and that's when they are called the parietal peritoneum. They become the membrane that lines the body wall. So the peritoneal cavity is actually the cavity tells the abdominal cavity. It's actually not the abdominal cavity, but it is actually a fluid-filled space between two peritoneums, and the fluid. The intention of the fluid is to lubricate mobile organs. So your mesentery, I mentioned to you the mesentery. Mesentery is a double layer of peritoneum. These are usually extending from the body wall to the digestive organ. They provide routes for blood vessels, for lymphatics and nerves, and they hold organ in place, and they also store fat. The, the intraperitoneal organs are the organs that are located inside the peritoneum. All of our organs are within the abdominal cavity, but some of them is actually in the cavity and is actually within the realms of the peritoneum. But sometimes some of them are outside of the peritoneum, which means they are located between the wall of the abdominal cavity and the peritoneum itself, in which case you call them retroperitoneal. The retroperitoneal organs are located outside or posterior to the peritoneum. They include most of the pancreas, the duodenum, and parts of the large intestine. And here's a good picture showing you the relationship between the peritoneum, and the peritoneum is the orange, the deep orange colored line is actually your parietal peritoneum, and that's actually covering your abdominal cavity. Now take note that the peritoneum will extend to pretty much go around an organ. That round space right there is considered to be part of the gut. And take note that the gut is covered by what you call a visceral peritoneum. The visceral peritoneum is actually an extension of the parietal peritoneum, and they are connected through a membrane that would anchor the organ and its peritoneum to the dorsal body wall. This is actually what you call the mesentery. Now, this is called the dorsal mesentery because it anchors and the organ to the dorsal wall of the body cavity. Now, there is also something that is going to anchor another mesentery that's going to anchor possibly a group of a portion of the gut into the ventral or into the anterior wall of the abdominal cavity, and that's what you call the ventral mesenteries. And sometimes you find organs that are connected with what do you call this, with peritoneal folds. You call the mesenteries are called peritoneal folds, but there is a name, a special name for peritoneal folds that would connect an organ and another organ, and they are what you call the omentum. Okay, this one here is labeled to be like a part of the ventral mesentery because I think it's coming and piercing right through the liver right there. But there is actually, if there's going to be like an organ right on the right hand side of the abdominal cavity, and they are uh, connected to the central organ right here, the central tube right here, by a peritoneal fold, you call that peritoneal fold the omentum. Now, whenever an organ, right, this organ right here, which is the third bottom image right here, is behind the peritoneum, you call that you call that position to be retroperitoneal. Okay, some clinical imbalances. Peritonitis is a term that's given to the inflammation of the peritoneum. It can be caused by, uh, well, possibly an accidental wound, okay, a perforating ulcer or a ruptured appendix, okay, and Here the peritoneum, when it gets to be inflamed, would end up when it's going to end up inflamed. Its tendency of the body will be to heal it, and as it is healing, it could actually stick together. Okay, pretty much that's not really very good. It can develop adhesion. The patient can actually develop adhesion if they stick together. But this particular inflammation will help localize the infection itself. But it's dangerous and lethal if it becomes widespread. Peritonitis needs to be cleaned up, or whenever a person gets to be would when a person would have inflammation of the peritoneum, it must be something that's causing the inflammation, and this debris must be removed, and the patient must be given mega doses of antibiotic. And this debris sometimes be coming from, let's say, something like if there's a gunshot wound or a perforation or possibly a perforating ulcer, all of the contents of the stomach here, okay, will get into and there's a lot of bacteria there, will get into the abdominal cavity, or maybe a ruptured appendix. Could you imagine if your appendix would rupture? All of the dirt that is actually in the appendix will pretty much like get into the abdominal cavity, and that's going to cause the inflammation of the peritoneum. So you need to remove that debris, and that will entail really maybe some surgery. Now, all digestive organs have the same four basic layers, and we're going to get into a review of the histology of the alimentary canal. And you call these basic layers a tunic, or you can call them tunica. Okay, so tunica refers to layer, and here you have your mucosa, your submucosa, your muscularis externa, your serosa, and pretty much the mucosa is your layer, the tunic layer, that immediately is in touch with the internal hole, which you call the lumen. And it functions pretty much um, different. The function of the tunics are actually different from one another. From with the mucosa, it will have three different functions. It secretes mucus, it secretes digestive enzymes and hormones, it absorbs the end products of digestion, and it protects against infectious diseases. So it is actually unique simply because it is the one that is uh, immediately in touch with the content of the stomach. That's why it has to be uniquely involved with the function of protection, because contents of the stomach is filled with bacteria, with absorption because the moment the contents of the tract has been um, digested fully, then it needs to be absorbed, and then of course, in order for this digestion to occur, it must have the necessary instruments to digest it, like your digestive enzymes, your mucus, and your hormones is actually supposedly located right there in the mucosa. And so it's made up of three sublayers. You have the epithelium, which is the exact cover of the mucosa, the underlying connective tissue, which is your lamina propria, and then you have your small muscle layer, which is actually a very fine muscle layer beneath the lamina propria, which you call the muscularis mucosa. So the epithelium of the alimentary tract pretty much is the mucus secrete. It's actually made up of simple columnar epithelium, and it's a mucus secreting cells in most of the tract. And huh, okay. So in the from the stomach to your from the stomach to your small intestine all the way down to your large intestine, you have simple columnar epithelium. However, in the mouth, in the esophagus, and the anus, they're all made up of stratified squamous epithelium. So they all will be non-keratinized, and therefore they need to be constantly wet. And some of them, on some areas, they secrete mucus. They protect the digestive organs from enzymes, and the mucus would pretty much like ease the passage of food right through the tract. Now, they may secrete enzymes and hormones. For instance, your stomach secretes the gastric juice, and your small intestine would have the intestinal juices around in order to continue with the digestion, the unfinished digestion in the stomach. So, Eulamina propria is made up of connective tissue. They're mainly loose connective tissue, areolar connective tissue. They have a very rich supply of capillaries, and they're needed really for nourishment and absorption. The lamina propria also would contain lots of lymphoid follicles that help the area defend against microorganisms. And pretty much they are made up of small follicles that are part of mucosa associated lymphoid tissues. And then finally, you have under that your muscularis mucosa. The muscularis mucosa is made up of a thin layer of smooth muscle that produces local movement just for the mucosa alone. And most of the time, the muscularis mucosa, the nature of the tone, the holding tone of the muscles of the muscularis mucosa pulls the mucosa into folds or villi. That's why some areas of the mucosa will have folds or villi. And here you could see a picture of the mucosa. This is your epithelium of the mucosa. Then it's followed by the lamina propria. Then you have a thin layer of muscularis mucosa. The submucosa, okay, is made up of areolar connective tissue as well. These will carry blood vessels, lymphatic vessels, lymphoid follicles, submucosal nerve plexuses, and that supply the surrounding GI tract. And they would have many elastic tissues that help the organ to regain shape after pretty much storing large meal. And finally, you have your muscularis externa, the main muscular um, layer of the gut itself. They are responsible for the movement of the tubes, such as your segmentation and peristalsis, is actually done by the muscularis mucosa muscles. They contain an inner circular layer and an outer longitudinal layer. And the circular layer thickens in some areas to form um, what you call a guard to open a guard that would pretty much prevent the abrupt passage of food between two different tubes. And you call this valves or sphincters. And they are made of very thick circular layer muscles. So, it is covered by, on the outside, the outside of the tube is covered by a serosa. This is the outermost layer. It's made up of really the visceral peritoneum that we're talking about. It's formed from areolar connective tissue that's covered with a single layer of squamous epithelium in most organs. But if the organ is not inside the cavity and is actually like in between tissues, then you would not expect a cover of serosa. They are actually covered by fibrous connective tissue, which you call adventitia. And this is very typical of organs, gut organs such as the esophagus. You will not find the esophagus in the abdominal cavity. The esophagus is within the mediastinum, and um, they are it is actually surrounded by connective tissues, and so therefore the esophagus is not covered by a serous membrane. It is covered by uh, a layer of adventitia, or a layer of fibrous connective tissue, which you call the adventitia, and it's made up of dense connective tissue. And there are some retroperitoneal organs that have both adventitia and serosa, depending on how the extent of them being retroperitoneal. Okay, so the blood supply is called the splanchnic circulation, and it includes arteries and branches of the aorta that serves the digestive organs. These will be your hepatic, your splenic, your left gastric arteries, your inferior superior mesenteric, and you've done this already in your circulatory system. Then you have the hepatic portal circulation, which drains rich nutrients from the digestive organs and delivers blood to the liver itself for processing. So, how is the digestive system controlled? First of all, guys, your GI tract has its own nervous system, and it is referred to as the enteric nervous system. They call it the gut brain, right? And it will have more neurons, really, than the spinal cord altogether. So the gut brain is made up of many millions of enteric neurons that communicate extensively with each other. Major nerve supply to the GI tract wall will actually be controlling the motility of your GI tract. So take a look at this picture here. This picture here pretty much will show you it's a contrast it's a contrast picture showing you the enteric distribution of neurons that is actually in the digestive tract, from your esophagus to the stomach, all the way to the different to the very long um, small intestine. It's made up of two main interconnecting intrinsic nerve plexuses, the submucosal nerve plexus and the myenteric nerve plexus. So how is the pathway um, formed? Well, it actually it comes from when you're actually like seeing food, maybe smelling food, or even just thinking of food. Okay, it's received by your brain, and there should be two pathways in it, but the pathway that delivers it to the gut will be from your brain. It is picked up by a local intrinsic nerve plexuses, which is the series of the gut brain, and then it's delivered to the effectors, okay, which will be your smooth muscles or glands right there in your stomach or intestinal wall. And then there's going to be a response to it, a change in contractile or sensory activity, which means when you are not even putting food in your mouth yet, but yet because you are thinking about food, you could feel um, that your stomach is already moving and growling and telling you, hey, you're hungry, right? So this is actually what you call the internal stimulus that could actually be brought about by this particular the internal stimulus that could be the source of the reason why you have a response. Your internal stimulus could be a change in the GI tract stretch, or the lumen, the pH, the nutrient or the solute concentration. Then it will be picked up by chemoreceptors and or osmoreceptors, and it will be sent to again to the plexuses, and it could go around. Okay, and then these particular receptors will send the stimulus again to your central nervous system. So your stimulus could be your external stimulus, where you see where you see your food or smell your food, or it could be an internal stimulus that is actually telling you that you can be hungry. And it's all being received and coursed into the brain. But then, of course, it all ends up in the response. So let's take a look at the three concepts that regulate the GI activity. First of all, your digestive activity is provoked by a series of mechanical and chemical stimulus. The receptors that are located in the walls of the GI organs are the ones that receive this. They respond to stretch, change in osmolarity and pH, and presence of substrate and end products of digestion. Then you have the effectors of the digestive activity, which are your smooth muscles and glands. And when they are stimulated, receptors initiate reflexes that stimulate smooth muscle to mix and move lumen contents. The reflexes can also activate or inhibit digestive glands that secrete digestive juice or hormones. And finally, you have your neurons' intrinsic and extrinsic activities and hormonal controls that regulate digestive activity. This would be actually the nervous system control itself of the digestive activity. Intrinsic controls would involve short reflexes. These are the enteric nervous system. And extrinsic control involves long reflexes, which is your autonomic nervous system controls. Then, besides the nervous system control, you have also the hormones. Hormonal controls. Hormones are coming from cells in the stomach and the small intestine. They stimulate the target cells in the same or different organs, and they stimulate them to secrete something which is actually part of the digestive juice or contract in response to the need. So let's take a look at the functional anatomy of the different organs. I am not going to be discussing all of them because these are all like reading and studying things, and you will have to observe in the lab, and that's why you have your lab. So first of all, let's take a look at the mouth. This is where food is chewed and mixed with enzyme containing saliva, and it will begin a process of digestion. When food gets to be mixed with the saliva, you do not anymore call that food. You call it bolus. And bolus now is going to be swallowed. Okay. The associated organs in the mouth would include the mouth, the tongue, your salivary glands, your teeth. Okay. And all in all, they are in a cavity which you call the oral cavity or the buccal cavity. They're bounded by the lips, by the cheeks, by the palate, okay, by the palate superiorly, and by the tongue inferiorly. And the anterior opening is what's called the oral orifice. The walls of the mouth is lined with stratified squamous epithelium. So your inner cheek cells are stratified squamous epithelium. Now, they are made of tough cells that would resist abrasion because they're made up of several layers. They're stratified. The cells of the gums, the hard palate, and part of the tongue are keratinized for extra protection. The lips and the cheeks, your lips or labia, is composed of uh, the fleshy muscle, which you call orbicularis oris, or in your AMP1, we call it the kissing muscle, right? The cheeks are made up of your buccinator or buccinator muscle, which is your sucking lips. And then your oral vestibule. This is recess internal to lips and cheeks and external to the teeth and the gums. Then you have your oral cavity proper, the mouth itself. Then you have a labial frenulum, which is a median attachment of its lip to the gum. Okay, let's take a look at, Well, this is actually when I say part of the lab, I am not going to be discussing this because you're going to have to look at it in the picture, okay, and study it and what they are and what their functions are, okay. So your tongue occupies the floor of the mouth. They're very muscular. They're made up of skeletal muscles. They are for gripping, repositioning, and mixing of food during chewing. They are for the formation of bolus, okay, a mixture of food and saliva. They initiate swallowing, speech, and taste. And the intrinsic muscles can actually change the shape of the tongue. And there are also extrinsic muscles that alter the tongue's position. And that's the reason why it's capable of mixing things around, and it's capable of making us talk. It's part of speech, the speech process. Now, the lingual frenulum is or what do you call this, a membrane that attaches the mouth to the floor of the mouth. Now, the tongue or the surface of the tongue would pretty much have that roughness on it. It is because it bears papilla. They are like um, peg-like projections of the underlying mucosa. When you say peg, that doesn't mean that they're hard as wood. No, they're just like the same, um, the same type of what do you call this? It's actually still soft tissue. However, the shape is like peg-like projections, and these peg-like projections are what's called papilla. And there are different types of papilla. The filiform papilla gives tongue roughness to provide friction, and they are the only one that does not contain the taste buds. It gives the tongue a whitish appearance. This is the filiform papilla. So when you're cleaning your tongue and you're trying to remove that white stuff, you're not ever going to be able to do that, pretty much, because the filiform papilla is actually the one that gives it a whitish appearance, and you're not going to be able to scratch off the filiform papilla. It's part of your tongue. The fungiform papilla is shaped like a mushroom. It is actually scattered widely over the tongue. Its vascular core causes reddish appearance of the tongue. And the next one will be a bigger mushroom. It still looks like a mushroom, but it's a humongous circumvallate papilla. And it forms about a V-shaped row at the back of the tongue. There's about 8 to 12 large circumvallate papilla at the back of the tongue. Then you have foliate papilla located on the lateral aspect, on the posterior aspect of the tongue. And your terminal sulcus, which is at the end, it's a groove located posterior to the valid papilla. It marks uh, the division between the body of the tongue and the root of the tongue that happens to reside in the oropharynx. This terminal sulcus does not contain papilla, but would still be bumpy because of the lingual tonsil that is pretty much like lying deep in its mucosa. And here is a picture of your tongue. Okay, it will show you the uh, the valid, the papilla, the circumvalid papilla. Then this is this part here. You will have a lot of filiform papilla, and you will have scattered fungiform papilla. Okay. Okay, so you have your clinical imbalance. The ankylosing is a congenital condition where children are born with extremely short lingual frenulum. And that's the reason why they're called tongue tied. But this is really a disorder or fused tongue. And the only way really to correct them so that children with um, ankylosing will be able to speak properly, they are treatable, will be to snip off the frenulum. And that would pretty much like uh, do the trick. I have a friend whose child really had ankylosing, and she had her child's tongue friend limb snipped off, and boy, now the child is already a teenager, and he couldn't stop talking. He's that's really that really did the trick. All right, saliva is uh, a secretion that is secreted into the mouth. It cleanses the mouth. It dissolves food chemicals for taste. It moistens the food. It compacts it into the bolus. Okay, remember that when food mixes with saliva, you call it bolus. Then, because of the enzyme that's in the saliva, it begins also the breakdown of starch because you have the salivary amylase in the saliva. Most saliva produced by is actually produced by major salivary glands, and it's located outside of the oral cavity. And um, there are also minor salivary glands that are scattered throughout the oral cavity, and pretty much they slightly help in the production itself of the saliva. So the major salivary gland, these are located outside of the mouth itself, would include your parotid gland. The parotid gland is anterior to the ear and external to the masseter muscle. Your parotid duct opens into the oral vestibule, which is actually next to the second upper molar, and would drain saliva into the mouth. Then you have the submandibular, which is medial to the body of the mandible. Okay, and then you have and it opens at the base of the lingual frenulum. Then you have the sublingual. The sublingual is anterior to the submandibular gland. It's under the tongue. It's actually behind. Okay, so it will have about 10 to 12 ducts that would run saliva into the mouth or floor of the mouth. So right here is a picture. This picture is also in your lab. Okay. You have the parotid gland right there. You have the submandibular. Okay. And then you have the sublingual right there. The sublingual is under the tongue. Your submandibular is just right by the ramus of the mandible. Okay. And here's a good picture of your salivary gland showing you mucus glands, those are the mucus glands, and serous glands. Those are the serous glands would be darker in stain. Right there, those are serous glands. But the mucus glands will be like transparent. The darker serous cells pretty much are forming what you call the serous acini, okay, in, let's say, submandibular gland. Submandibular gland would have a 50-50 mixture of mucus acini and serous acini, your submandibular glands. Your um, your other glands, though, would have a different histology also. So salivary glands are composed of, there you go, two types of secretory cells. They produce, the serous cells produce water secretion, and they're also secreting enzymes and ions and a little bit of mucus also. But the mucus cells produce mainly mucus. That's why you see them looking like, your, like they look like a clustered follicle that's filled with goblet cells, right? But goblet cells are individual cells, but they are transparent, and you could see the nature of the goblet cells. It's a actually mucus producing cell. It's transparent. Look several goblet cells and put it like in a flowery acinar type, and then you have already the mucus acini. So your parotid and submandibular glands will contain mostly serous cells. Although your parotid gland contain mostly serous cells, your submandibular contain a mixture of the serous and the mucus cell, but the sublingual is actually mostly mucus. So that's the difference between those three. But if you see anything that would be like a mix, it would be submandibular. That's actually a mix. But it has a lot of serous, but your parotid gland would carry mostly serous. Hardly will you find mucous cells, if at all you will find. The submandibular you will find in some areas mucous cells, but they are also mostly serous. But the sublingual is would not hardly you will not hardly see any serous cells. They're mostly mucus. Okay, let's take a look at some homeostatic imbalances. Serostomia is dry mouth. It's an uncomfortable condition that's caused by too little saliva being made. And because you don't have any saliva, the saliva is very important in your mouth. And uh, the reason why when you are chewing gum, you feel that your mouth is refreshed is because by the motion of chewing you're actually activating your salivary glands and you're pumping more saliva. So when you are chewing gum you are producing more saliva, and the saliva is the one that's keeping your mouth fresh. It's not really the gum, right? It's actually the motion of the chewing. Although mint gives you that minty breath, okay, try chewing your gum the whole day, and if you lost already the mint, still your mouth will not fresh will not actually lose its freshness. It will not become stale, as it will not be smelling stale, because you are producing your saliva. And talking itself, the motions of talking and chewing pumps saliva in your mouth, and that's the one that carries the enzyme that kills the bacteria, and pretty much it's vital for oral health. So lack of moisture would lead to difficulty in chewing and swallowing, and it leads to oral infection. So this particular xerostomia can be caused by medication, or it can be diabetes or HIV or Sjogren's syndrome. It's an autoimmune disease affecting moisture producing glands throughout the body. And then you have, let's take a look at now the composition of the saliva. It's mostly water, okay? It's slightly acidic, about 6.75 to 7. It's lots of electrolytes in it. It has the salivary amylase. This is actually an enzyme that digests starch. And lingual lipase. This is an enzyme that would break down triglycerides, but not really uh, totally. It is very, very small absorbable pieces, but it helps. And pretty much you have your proteins, such as mucin, lysozyme, and your antibody, IgA. The antibody that's present in your saliva. And you got metabolic waste, urea, uric acid. Now, note that your lysozyme, your IgA, your defensin, and your nitric oxide from nitrates in food are actually the substances found in the saliva that protects us against microorganisms. So it is really, the saliva is really very important. So let's take a look at some facts about controlling salivation. First of all, we have 1,500 ml per day of saliva that is being produced. Minor glands continuously keep the mouth moist. The major salivary glands are activated by parasympathetic nervous system whenever you have ingested food that stimulates chemoreceptors and mechanoreceptors in the mouth, sending signals to your salivatory nuclei in the brainstem that stimulate the parasympathetic impulses along fibers, okay, in cranial nerves 7 and 9, all the way to the glands. And there is actually strong sympathetic stimulation in inhibiting salivation and results in dry mouth, which is what we're talking about, xerostomia. So the smell or the sight of food or even an upset GI tract can act as a stimulus in salivation. So let's take a look at some homeostatic imbalance about teeth itself. Take note that primary teeth, when it decays, can be very painful and can lead to serious infection. Some point in time when we were young, some of us might have experienced this. Primary teeth deserve as much attention as permanent teeth. That's why we train our children to brush their teeth properly. Not just to brush their teeth because we're preparing them for their like permanent teeth, but the primary teeth serves as an important placeholder for developing permanent teeth. So if you lose your primary teeth way before your permanent teeth comes out, then you won't have a placeholder there. That's when, crookedness or imbalances would pretty much result when permanent teeth comes out. Although that's not the only case. Some of the shape of our teeth really is because of our DNA. So primary teeth can be kept healthy by brushing and limiting exposure to sugar liquids, especially from prolonged bottle feeding. Okay, I am not going to be discussing the anatomy of the teeth because this is part of the lab. Okay, just want you to know, guys, that the teeth is for mastication, which is for chewing. Okay, it will be chewing is grinding and tearing apart the food into smaller fragments. And we have a dentition and dental formula. Your primary teeth is made up of 20 deciduous teeth or milk baked teeth, and they would come out between 6 to 24 months of age. And then underneath, there's actually waiting 32 deep lying permanent teeth, and they will enlarge and develop while the roots of the milk teeth are resorbed from below, causing them to loosen and fall out. Usually, this would occur during, well, from 6 to 12 years of age when we lose our teeth, and that's when we meet the tooth fairy, right? All right, so let's take a look at some of the teeth. All teeth but third molars. The third molars, which is the wisdom teeth, are by the end of adolescence will be out. The third molars may or may not emerge. Okay, they do emerge later between 17 to about 25 years of age. Teeth are classified according to shape. There's your incisor, which is shaped like chisel. These are your first two that are in front. Okay, canines will be more lateral, fang-like teeth that tear or pierce food and meat. This is remnants of our carnivorous diet. Premolars, these are broad. They have broad crowns and rounded cusps that are used to ground or crush. And here you start our our means of uh, snipping and chopping, rather crushing our nuts and vegetables. And finally, we even have broader ones, which you call the broad crowns, the second molars, or and of course the third molar. They have rounded the cusp. They are better grinders. Pretty much during chewing, the upper and the lower molar would lock together, creating a tremendous crushing force. So, this is actually a picture of human dentition. So, the dental formula is a shorthand indicator of number and position of teeth. And pretty much in the primary teeth, okay, you have two incisor, one canine, two molars on the upper jaw. So, this is actually 2I, 1C, 2M, both on the upper and lower jaw. And there's actually an equivalent of 20 teeth. So here's only this is actually 1/4 only of the upper jaw, and the other 1/4 is actually on the other side. So that's the reason why it's times two. So there's a total of 20 teeth. In the permanent teeth, you have two extras, and that will be your premolars. So there will emerge between your canine and your molars two premolars, both on the upper and the lower, on the right side and the left side. And that's why you multiply this by 2. That's actually right side or left side. And a total of 32 teeth. So the tooth structure, I am not going to be discussing this, but I'm holding you responsible. This is going to be part of your lab. So you have to make sure that you read right through your lab. Okay, it's part of the lab. Make sure that you know what they are. Just know, guys, that your canines, your incisors, and premolars have only one root. Okay, but the upper premolar often sometimes has two roots. The first two upper molars have three roots. Okay, the first two lower molars have two roots. The third molar roots would vary. Okay, often they are made up of single fused root. So this will be your lab, and I just included this here in a PowerPoint so you will have a glimpse of it. Okay, impacted tooth. Let's see, some homeostatic imbalances is a tooth that remains trapped in the jawbone and wouldn't come out. That's painful. It can cause a good deal of pressure and pain. And most of the time, the ones that are impacted are wisdom teeth, and these are the ones that are commonly involved. And the only way to get it out will be surgical removal. And pretty much, let's take a look at some of the dental tooth and gum diseases. Dental caries, cavities, and it's brought about by demineralization of the enamel and dentin because of bacterial action. Dental plaque, it's a film of sugar, bacteria, and other debris or dirt that accumulates there and adheres to the teeth and needs to be removed. That's why needs to be cleaned up. Acid from the bacteria dissolves calcium salt, and pretty much it is considered that these particular dental caries can actually be caused by this plaque and this acid from bacteria, the proteolytic enzyme that would digest organic matter. Usually you prevent it by daily flossing and brushing. Gingivitis. Goodness, people that are aging most of the time develop gingivitis. These are plaque that calcifies to form calculus because of tartar, okay? And calculus disrupts the seal between the gingiva or the gum and the teeth. Then you have your anaerobic bacteria getting into the area and infecting the gums. Usually the infection is reversible if you can remove that particular calculus or calcium deposit. Then you have your periodontitis, a periodontal disease. This has been, this is common among, what do you call this, seniors, okay, because of old age. The neglected gingivitis can actually escalate to a disease. This is when immune attack cells attack not only bacterial intruders but also the body tissues, and this can eventually destroy periodontal ligaments. They activate the osteoclast, which leads to dissolving of the bone and possible tooth loss. Uh, that's why a lot of seniors, okay, are actually losing their teeth to this. It may also increase heart disease and stroke by promoting atherosclerotic plaque formation. The bacteria can enter the blood, can cause clot formation in coronary and cerebral arteries. The risk factors here is smoking, diabetes mellitus, or even oral piercing because the bacteria can be um, taken in through these oral piercings. And that's it, folks. And I am going to um, follow this with another two more, the B and the C, within this week.